non-consanguineous marriage, resident of Govandi and hailing from Solapur, with informant being mother, came with complaints of cough since 3 days and increased work of breathing since 1 day. As per mother, the child started having cough 4 days back. The cough was dry, non-spasmodic, intermittent, not associated with any post-tussive vomiting. It had no positional or diurnal variation. The cough gradually increased over the past 4 days in intensity and frequency. Since past 1 day, child started having increased work of breathing in form of increased rate and depth of respiration. On inquiry, the mother tells that the child has always had fast breathing, which has now gotten worsened. There is history of OPD basis stabilization received 3 to 4 times in the past 1 month. There is history of cough 1 month back, which lasted for 2 days and subsided on its own. There is also history of forehead sweating noticed by the mother during feeding. There is no history of any suck cycle. There is no history of bottle feeding or oil installation. There's no history of fever or ear discharge. There's no history of recurrent admissions. No history of any bluish discoloration of the oral mucosa, and no history of inadequate weight gain. There have been no previous admissions. Antenatally, the antenatal period was otherwise uneventful, but during the 5th month in the ANC scan, mother was told that there is some sort of foci in the heart. Otherwise, there was no history of GDM, PIH, or hypothyroidism. There's no history of any drug intake in the mother. Birth-wise, the child was delivered full-term vaginal delivery, cried immediately after birth with a birth weight of 2.75 kgs. There's no history of any NICU stay, and the child was discharged on the day of life 3. Developmentally, the child is normal and immunized only at birth. Dietary-wise, the child is exclusively breastfed on cues about 6 to 8 times during the day, and each feed lasting for about 20 to 25 minutes. There's no history of similar complaints in the sibling.
Hello. Yeah, so 4-month-old has started with cough, which was dry, non-spasmodic, intermittent, and increased over 4 days. So at the age of 4 months, when a baby comes to you with cough as a complaint, how will you start? How will you approach this case?
Primarily, it could be a respiratory pathology, like if it's such an acute history of 3 to 4 days and there's only cough, there's no fever at present. So it could be a URT, like LRTI.
Respiratory or severe system involvement or GI system involvement. GI system involvement. GERD in serious, again, congenital heart diseases.
So all of you are right, but you are just enumerating the possible causes of cough at this age. What I am asking is, how should your mind work? How should you take further history, and what do you want to separate out from the history? So the first thing is that you should confirm whether the baby is actually coughing. So many newborns or many infants, they will just have noisy breathing, they will have ghar in their chest, which parents say usko cough ho gaya hai, and he's not actually coughing. So you are on a different track of analysis. So first thing is that. Okay. Now the second thing is, that he has started, if he is actually coughing, he has started coughing without fever. So, what does that tell you upfront?
More towards viral etiology.
Respiratory tract, or maybe because of regurgitation. There, uh,
So, first of all, does a 4-month-old get a viral? When will a 4-month-old get a viral?
there history in family.
There has to be a immediate family member's contact. Okay. Secondly, always remember that most infections should start with fever. Okay. If a infant has a cough and cold due to a viral, it will never be cough alone. It will be cough and cold. So your next question is whether there is a runny nose, blocked nose in association with that. So, in fact, what I was trying to drive at is that if there is no fever, upfront you are thinking of non infective causes. So, this is the way you start thinking that there's no contact, there's no viral infection, there's no fever. So, this is possibly non infective. Now, in non-infective, you gave us two, three answer possibilities. One you said is aspiration. One you said is cardiac. Then you said GER, which is aspiration. So, how will you say that this history looks like aspiration or this history looks like cardiac? So, what will be the history in a aspiration syndrome?
The cough would be sudden onset, and there'd be some association with the feeding pattern also.
History of regurgitation of feeds.
Very good. So, see, aspiration we say is always, we say it is something which can happen suddenly. But then at the same time, you must think why a 4-month-old should suddenly vomit one day only and that day aspirate. You're getting what I'm trying to say? So he has to be having frequent regurgitation, some bigger vomits, and out of those episodes, one day he aspirates. Okay. Now, technically, a good, well grown baby, normal baby, etc., will not aspirate that way. That is a kind of a mentally subnormal CP, whatever, who will aspirate. So, these children have micro aspiration, the GER persons. So, that is a different thing. It's not like one sudden event of aspiration, right? And in an older child, that sudden event is a different event. So you have to ask that history, whether there was frequent regurgitation, vomiting, etc. Right? What about cardiac?
There is history of success cycle or forehead sweating, and child may not be all right prior to this illness also. Um, there is no
So feeding, weight gain, whether mother noticed tachypnea, increased precordial activity, then suck cycle, all those things, right?
I think first thing to start history is, has the child been completely all right prior? We have been missing that point. Okay, the story starts from there. You must confirm that this started only 4 days back. Now the mother says yes. Then you need to ask further why she thinks the baby has been doing well. Has she been feeding well? Has she been sleeping well in between feeds? Does she cry loudly when hungry? Is she passing bowels, urine all right? Several things will tell you that it may not be. Plus, on the top of that, if she has been going to a facility for vaccination, has she been weighing the child? Has the weight been going proportionately? You will get some clue that this probably started much earlier. If you get that clue, you are sure that it is something of a congenital malformation. If you are a story that everything is going well and nothing is happening, then it's the recent disease. And like I think Dr. Mohita had put up, that could it be a viral infection? Okay. Not necessarily there would be fever. Then how would you rule out viral infection? Cough is the, and fever, absence of fever is not necessarily against virus. So the history, whether the mother has been having viral infection or anybody else having. Now this takes away from viral infection if you got the story that the baby was absolutely all right. Now suppose it was an aspiration for the first time at that time, severe, then there is a choking episode, or it could have happened while feeding. So some more details about how did that start. So obviously this child was never normal prior. Now even if the child, what is cardiac breathlessness? A comfortable tachypnea. What is the respiratory breathlessness? Increased work of breathing. Now this child has started more increased work of breathing, which means earlier there must have been comfortable tachypnea already. But you would get it only if you get convinced that the story started. I think finding origin of the disease is the most important point. And then only you can tell. Now, I think Dr. Kare in this clinic must have said umpteen number of times, any infant who comes for the first time with respiratory problem at 3-4 months of age is cardiac till proved otherwise by common etiology. So everybody knows this is a cardiac problem. But in an exam, you will not be tested only for cardiac. You will be asked why not many others. And therefore, it is very, very clear, right?
So everything is covered. One wonders why a child is brought only for cough for 4 days. That means the cough is significant. Otherwise, just a little cough and small baby will not be brought to the doctor. That means significant cough at 4 months, and then all our line up and without fever, and maybe then further thing, no contact with any similar illness. That goes obviously. Maybe if you ask the mother, इधर दर्द दर्द आपको महसूस हुआ है क्या, you may get a history of palpitation which mother may not come out with upfront.
This is a dry cough, no? It is upper airway. What are we talking? Lower airway problem. She said dry cough. Dry cough is upper airway. So where are we now? Heart problem is not upper airway. So this is not a cardiac problem. Come on, argue against.
So there is no sputum since the child cannot expector it. So interpreted.
How do you know that this dry cough is really coming from the lower airway? You are right.
Tachypnea. Then indicates lower respiratory tract.
Therefore, tachypnea if noticed, but otherwise the noisy chest. The chest appears noisy. Many mothers would say, खांसी आती है भरी हुई है. Actually not cough. So take a note that dry cough doesn't mean it's not lower airway.
Even history of
Yeah, I just wanted to say, it is commonly thought that dry cough means upper airway and lower cough. It is not true. For example, those who are hyperreactive airway, for them any cough is with wheezing, whether they are dry or wet. Today if it is dry, tomorrow it's going to be wet.
very often when you are giving history, you give history of nebulization. What does it mean to you?
Cardiac wheeze.
I'm just first generally asking. We'll come from broad to narrow. So if any child you get a history के इसको पहले nebulize किया था, what interpretation you get from that? I'm asking that.
if the mother is saying that the child has been receiving nebulization 3 4 times in the past 1 month, she has been to the doctor 3 4 times, there is something that is going on, that is why she is going on again and again. So there is base level, maybe she was saying that she was going for tachypnea and she felt that the child was breathing fast. So there is something, if the child is getting nebulization again and again, then probably there's something in the chest. That's what she's saying.
LRTI. The child might be having recurrent pneumonia or
Currently. So there are recurrent respiratory illness. We don't know if it is wheeze or, but child has symptoms.
So, what I want you to understand is that two things. One is always ask, why did you go to the doctor? That is your first question. So, they may have gone to the doctor because the baby was actually coughing, what we just discussed, or they noticed breathlessness, or they went only for a noisy chest. These three things you have to separate out. The second thing is, remember that at most places nebulization is done for anybody who comes with respiratory complaints. So what I'm trying to say is you can't equate it to wheezing or rhonchi or reactive airway disease or whatever, right? Now here you've got so you said that that means the cough was there even earlier. So this mother went to the doctor earlier also. So your 4-month-old first time cough is thrown away. It is now past history of cough also. And we've discussed that this is now mostly likely to be cardiac, right? Now, forehead sweating, yes, but suck, no. Is it possible? Are we getting wrong in the history, or what do you want to say? Is this baby in cardiac failure or not in cardiac failure?
For suck cycle, the mother kept on saying that the child is feeding well, the child is gaining weight also, and there has been no disturbance in feeding. But she's saying that sometimes she has noted that, and the forehead sweating also, she's not saying it is persistent. She's saying that she is sometime noticing that it is present. Not likely to be there, but
How do you ask for a history of suck cycle? You can talk in Hindi or Marathi. What question will you ask the mother?
बच्चा दूध पीते-पीते रुक जाता है क्या? रुक के साँस लेके फिर वापस पीना चालू करता है क्या? या फिर दूध पीने में कितना समय लगता है? मतलब कितने देर तक बच्चा दूध खींचता है? तो आपको लगता है क्या दूध पीते खींचते-खींचते थक जा रहा है?
So, does a normal baby suck continuously from the moment the baby starts to the end of the feed? They live in between.
एक बार में like they don't suck for one time and then just stop. Like repeated sucking they'll do, but they'll not stop, they'll not gasp or they'll not wait in between the feed. If the mother was perceiving that between the feet the child is taking longer duration and is taking time, like he's leaving the breast and then he's taking again latching again, then that is more like a suckler.
The child, most of the babies will suck, and first in the beginning they will suck vigorously. They won't look here and there. 80% of breast is evacuated in first 5 minutes. They are very hungry. They are not interested. Then when they are half full, three-fourth full, then all the nakra starts. Then they will open the eye, look here and there, smile, then go back to breast, etc. So ask the mother after in each interval when the child starts sucking, does he stop sucking? Not because of anything, but because she's full, or she stops because of breathless. The suck rest cycle is suck, breathlessness, and then stop, and then suck. So she may have noticed that child is breathless, but she may not complain. But when say बीच में जब छोड़ती है तो सांस चली हुई रहती है क्या? Then the history may be yes, there is like that. Some degree of tachypnea all the way because breastfeeding is exercise, but it will be noticed by the mother if it is more.
Why forehead sweating?
Sympathetic overactivity, there is sweating over the forehead.
So why only forehead? Sympathetics are all over the body, no? Okay, and suppose you and I are tense, do we get forehead sweating if our sympathetics are activated? We get. So the sweat glands are more in number on the forehead, and that's why it is obvious, right? Okay. So now you've said this is a heart disease.
Cystic fibrosis.
Okay. So any thoughts on cystic fibrosis? Can this be cystic fibrosis? Will you think of cystic fibrosis?
Don't know the age. I don't know the age of the. Is
There is a poor weight gain and wet cough, sir, and also there might be history of not meconium.
So you look for other corroborative history suggestive like meconium ileus, etc. But if it is cystic fibrosis at this age, then they are likely to have fever as an infection. And then this baby will be quite unwell and all that. So this history doesn't look like cystic fibrosis just now, right?
And I think all metabolic disorders which present very early are a severe defect. So CF may not present for years also. And I recall on few occasions a typical CF in an infant, but the father said he's also having cough off and on. They said it's allergy, but he had also CF and he was not doing too well in health. So the point is, if CF presents very early, it presents as an acute respiratory distress in an ICU and often mistaken for pneumonia. Fever may or may not be there. And then the clue is he's breathless and he has a metabolic alkalosis instead of respiratory acidosis. That's the first clue that you are not really looking at an acute respiratory problem, but a secondary to something else. And I think that's why this is not CF. Weight loss is there in cardiac problem also. Feeding difficulty is also there. To pick up any abnormality of stool is too early at this age because he's not taking much fats in his diet. And therefore, that history will not be so important at that age. But most important is severe the defect, early and acute manifestation. And this is not that. Now, a month ago, there was some call. Okay. So this is slowly developing problem and therefore CF is out at this age.
Now you come to heart disease. So cyanotic or acyanotic on history.
Acyanotic.
Can it be cyanotic? Means if mother has not noticed cyanosis, is it sure that this is a acyanotic heart disease?
Admixture physiology.
So admixture physiology is possible. Usually they will have what with mild cyanosis? Failure. So the failure doesn't seem to be very prominent. So to that extent, no, but you can't 100% rule it out. So in exam, you will say that mostly acyanotic, but I will confirm on examination because an admixture physiology comes with failure and mild cyanosis. Okay. So if it is acyanotic, then which defect? On history, what do you think? ASD, VSD or PDA? Why VSD?
age of presentation, the ASDs are usually asymptomatic and they usually, well, the small ASDs, they go unnoticed. They don't come, they don't come so early. Could be VSD or a PDA, and but age-wise more likely to be VSD if a 4-month-old is first antigen.
Actually, if it's a mildly cyanotic heart disease, but they have not seen persistent cyanosis, then of course, one thing you have to ask is if the baby cries, do you find blueness? Not otherwise. That's one question. The second is for example, anomalous pulmonary venous drainage. If it is a partial one, then it might totally fool you. And sometimes it is diagnosed as an ASD as well if you miss out on that. Then at that time, what is the clinical story like? Because there is some hypoxia already, though not manifesting as cyanosis, the hemoglobin may look too good. And therefore, at 4 months, a normal baby's hemoglobin is dipping down. But if this baby is 12, 13 grams, then you start wondering, why is he having so much of that? There must be a silent hypoxia underneath. So sometimes the good hemoglobin, one would say, oh, it's very good. But he's not supposed to be having that very good at that age. So that may be another. And if it's a total anomalous venous drainage, then they often fool us like a bronchiolitis. They come only with certain breathlessness. So sometimes an acute bronchiolitis so early might be even a total anomalous pulmonary venous drainage.
Dr. Mohite has pointed out that CF always has a wet cough. So that is one point. And then Dr. Palniraman says PDA is more common in preterm, right? We know. Fine. Come summarize.
A 4-month-old child, second by birth order, birth and developmentally normal, partially immunized, brought by mother with complaints of cough and increased work of breathing, is probably a case of LITI in a case of acyanotic congenital heart disease with increased pulmonary blood flow, not in CCF, with probable lesion being a VS.
He has cough because of LRTI, that is infection, or because of venous congestion. Without fever. Possible, nothing is impossible, but just wanted to point out the word LITI is a what includes everything perhaps, and there may be an element of infection, there may not be an element, especially in a congenital heart disease with left to right significant shunt. There may be other causes for cough without infection.
On again. On presentation, the child was irritable, febrile, a pulse rate of 166 per minute, normal in volume, regular rhythm, a respiratory rate of 62 per minute with subcostal and intercostal retractions. There was a differential SpO2 noted in the when the child was brought. It was In the upper limbs, it was 96 and 92%. In the lower limb, it was 77. It showed up to 85%. But the perfusion was maintained. Anthropometrically, the child is normal. Like everything is between third to -3 to -2 standard deviation. On head to toe,
You're saying -3 to -2, then how are you saying normal? Then normal nahi. Let us be very clear what is normal. So normal is still what standard deviation? So if it is less than -2, then weight and length are both not normal. They are below normal. So don't say normal. In exam में आगे जाओगे ही नहीं, इधर ही अटक जाओगे. Okay?
the differential, matlab, SpO2 is different in the lower limbs. So they could probably, because of, as we discussed, admixture is one possibility. Usually it would be in PDA where there would be a differential SpO2. And second is cyanosis was not evident, but probably. But actually later on, in when the child was in the ward, again, after that, there was no differential SpO2 that was noticed. But the first time that the child presented, there was difference.
So why could you have got that reading?
Cold extremities, which is falsely low. If the other readings are not later coming normal and equal, then can be falsely low.
A pulse ox depends on your perfusion, and if your perfusion is not good, then you'll have fallacious readings.
On head-to-toe examination, everything was within normal limits. There was no pallor, icterus, clubbing, cyanosis, or edema. Everything else is within normal limits. On systemic examination, cardiovascular, on inspection, the chest wall was appearing symmetric. There were no visible chest pulsations. On palpation, apical impulse was palpated in the fourth intercostal space, lateral to the midclavicular line. On auscultation, a pansystolic murmur was heard best in the second, third, and fourth intercostal space. Just parasternally. On respiratory system examination, child had tachypnea, intercostal and subcostal retractions. On auscultation, bilateral wheeze and conductive breath sounds were present. Air entry was reduced bilaterally. On per abdomen, it was soft, non-tender, and there was a liver of 3 centimeters. Spleen was not palpable.
So Dr. Mohit is asking whether the SpO2 got normalized with oxygen or with after giving oxygen, or
Initially, the child was put on oxygen support, after which it corrected. But then, in the course of ward, the child was on room air also. Then also the SpO2 was normal later on.
means question is, does a SpO2 which is low because of a cardiac problem get corrected by giving oxygen?
That is how we differentiate usually between respiratory and cardiac.
So just you have a pansystolic murmur and you have a apex.
ते चला जाऊया परी जायचं मी जाऊन कुठला ऑर्डर देऊ मग हा
So, a 4-month-old boy with lower respiratory tract infection without respiratory failure, with history of forehead sweating and differential limb saturation with murmur, probably a case of LRTI and a acyanotic congenital heart disease, probably VSD. On investigations, initially when the child came, so initially the child was tachycardic and tachypneic. the tachypnea could due to be on palpation, the apical impulse was मतलब usually अगर 4 month old के लिए fourth intercostal space में मिलता है तो वहीं पे that was not deviated मतलब it was not suggestive of any hypertrophy. And on auscultation, there was only a pansystolic murmur. The murmur was heard all over, but it was best heard in the second, third, and fourth intercostal space. There was no other splitting or any other sounds. Any other murmur was not noted. And on the respiratory system, there was bilateral wheeze and conduction.
I would have expected was there was hyperdynamic pulse. And in addition to the pulse being felt at the apex, there must have been some pulsations lateral to the left border of the sternum. So hyperdynamic left apex, telling you thereby what? A diastolic overload. If the ventricle apex was at normal place, probably no significantly detectable ventricular hypertrophy. Otherwise, it would have shifted either down or out. So clinically, at the moment, no, but hyperdynamic circulation. And hyperdynamic circulation means usually a systolic overload or diastolic overload. A diastolic overload, probably of the left ventricle, and the pulse around the left sternal border also suggests that there may be an element of RV also. So diastolic overload in a child with LV and RV, in a child who has pulmonary plethoric lung fields, VSD becomes your first diagnosis. What I wanted you to do is analyze each symptom and give its interpretation. It may have limitations and then suggest whether it is this. If it was PDA, it would have been left ventricle prominently. The right parasternal would not have come. The pulsations would have been little different. Okay.
In exam, giving diagnosis of VSD is not enough. You must talk one, whether it is a small, moderate, or large. Second, of course, is there a pulmonary hypertension? And the third, whether there is any cardiac failure. You already said there is no abnormal rhythm. So would you guess whether it is a small, moderate, or large? And tell us on what justification you have said small, moderate, or large.
There is no pulmonary hypertension, sir, and but it has um, symptomatically presented at the age of 4 months. We can consider moderate.
Why not small?
Keep in mind the child is moderate wasting is present. So significant weight loss is not there. So large VSD unlikely. Since weight is not normal, it not small VSD also.
How does length of the murmur help you decide?
Defect, more the murmur. More is the defect, lesser the murmur.
So then it should be small, no? Because it is pansystolic.
Louder the mother. It is pansystolic, even small, moderate, or large, sir, but the loudness of the murmur depends on the defect. Or
What you would have said is the small VSD doesn't present only with symptoms. So the very fact that he has presented with symptoms has to be moderate. It can't be small, right?
What I mean is that one way to decide is also the length of the murmur. Then other you already said whether hypertension or not. So that is important. Now here, therefore, in an exam, you need not say pansystolic. Okay, then you are safe. You're not asking for many more problems. And I think That is what I meant. But typically, so what does pulmonary hypertension develop? When moderate VSD has gone on further. And therefore, in a small VSD and the initial phase of moderate VSD, there will not be a pulmonary hypertension. And thereafter, of course, so could VSD present without a murmur? We said pansystolic, short systolic. Could it be without a murmur? How can it be without a murmur?
A large defect can present without a murmur also.
Therefore, the large could be even without, of course. And by then, of course, you have a very bad sick child, a large heart, etc. So that you know. And therefore, this looks like a moderate to severe almost, coming so early, manifesting really even a month or two back. And look at the -2, -3 anthropometric measures, it must have started silently even earlier and now manifesting more. So it's almost amount to moderate to severe VST.
This 2D echo was actually done prior to this admission. It actually showed a top physiology. The child has 2 mm OSASD with large perimembranous VSD and a severe PS.
I think one more characteristic that you should mention is a diastolic murmur, which is very important. And tell us whether diastolic murmur, what does it convey in a VST?
Yeah. Diastolic murmur in a VST. Maybe. Yeah.
MDM, mid diastolic murmur, heard at mitral area. Because in a VSD which has got a large VSD and good pulmonary circulation, pulmonary hypertension has not developed, a large amount of blood is flowing from the left ventricle into left, from the left atrium to left ventricle, because the circulation across is good. And you will see a very soft mid diastolic murmur, which can be appreciated as absence of silence, you can say. That means diastole is not completely silent. Something clicked in between because it requires a trained mind to pick that up. If the MDM has disappeared, that means the flow of blood across the mitral valve, that means from left atrium to left ventricle, has disappeared. And that will happen in when the pulmonary hypertension is developed. So if there is MDM, you are relatively happy. And if there is no MDM which was present earlier, it may indicate that this child has developed significant pulmonary hypertension. But it is difficult to appreciate that MDM. But try and auscultate if it is present.
So what did we miss and why was the diagnosis fallows? Did we miss something clinically? Cyanosis, so there's no history only, so that is fine. We said it's possible, but with respect to VSD versus fallows, what did we miss or what should we have given more importance to?
If there is no P2, single.
One is a single second heart sound. What else? So there should have been some pulsations on the precordium, either the ventricular pulsations or parasternal or whatever. So VSD, as Karesar already said, is a hyperdynamic circulation state. So if there were no pulsations, it should have raised a bell. Okay, why there are zero pulsations? Why you are not looking? Why is it not like LVs prominent, and that could have, brought that question up, is this something else, right? So that's the importance of all those pulsations which you see on the precordium.
Even in the history now, look back, a month ago there was a cough for 2 days and then that disappeared. That should not have happened really. That may not be related to whatever we are talking about. So that is one. Second is look at the apex. It is in the fourth intercostal space. Though it looks like outside, it must have been really not very outside. In a small infant, it's not easy to make out, but fourth is certainly absolutely within normal limits. So there's no reason why we call it a left ventricle at this point of time. Then you said pansystolic murmur. Why are we getting early VSD manifesting with pansystolic murmur? So these are some of the clues. The examination findings appeared, but there were some problems for us. And therefore, as he said, that uh, the diastolic murmur that we have not mentioned at all. So this would have been the way to go by. Again, earlier somebody on the chat had mentioned that how severe was the cough? Because that may be an important issue to say that yes, it is a lower airway problem which is worsening. So all this put together, finally she said that there is no cardiac failure. Our child of large VSD coming very early would have come with some cardiac failure. Then the question is, what is this forehead? Okay, in this part of the country, every forehead is sweating. So the question is, we don't go by that alone. But she clearly said, no Sakra-Sak cycle, but still forehead sweating. So these two, in fact, such Sakra-Sak cycle is easily noticeable, complained of. Forehead sweating is not a prominent complaint by the patient. So again, we could have said, why is that kind of disparity? See, every time we learn what we could have asked more, and I'm sure even we did not realize to ask those details. But I know, I think Mahesh Mohite had asked, how was the severe cough? Every point, therefore, is important. So I think while taking the history, be an undergraduate. Ask every question that you have learned in the first medical term. Thereafter, when you get senior, you feel there is no reason to ask all those questions. And I think that is what this patient has taught us.
Also, sir, this pulse ox 96, do you think that is
The point is that that's see, but otherwise at other places it was much lower. So the question is, like you said, that there may be other reasons why it was not picking up, etc. But we need to check that disparity looked too much. So we said it could not be environment alone, because why only left lower limb so much, so bad, etc. So that could have alerted us that why there is so disparity. We need to check again. Then already somebody had said that give oxygen and see whether without oxygen you saw it. So I think all these possibly, see, we miss so many points in asking details. That's why we presume the story. Okay, again, story of tachypnea. Okay, so that should not have been an issue. We said chest retraction, all that, silent precordium. So many things went against this typically as a fellows.
Uh, Palpation is very important. Palpation tells you which ventricle is hypertrophied and which kind of overload is there. Because they are quite separate and distinct things. Right ventricle, systolic overload, right ventricle, diastolic, so also biventricle. Perloff mentions in his introduction that in pediatric cardiology, your hand is your secret. That means the palpation is so important. We should try and learn that more and more.
Good evening. Uh, a 3-year, 1-month-old girl, twin A, born out of non-consanguineous marriage, resident of Sion, hailing from Buldana, Buddhist by caste, brought by and informed by mother with a complaint of fever since 5 days, yellowish discoloration of the sclera since the past 4 days. Child was all right 5 days back, after which she had fever, intermittent, which was documented 100-degree Fahrenheit fever, 1 to 2 spikes per day, not associated with rash, chills, or anger. It was relieved on medication. Child was active during the interfebrile period. There was yellowish discoloration of the sclera noticed by the mother, insidious in onset, initially over the sclera, followed by face and body, gradually increase in intensity over the period of 4 days. It is associated with high colored urine, no history of vomiting, no history of pain in abdomen, no history of decreased appetite, no history of abdominal distension, no history of outside food consumption, no history of drug intake, history of inability to gain weight is present, history of pica is present, no history of blood transfusion in the patient or the family, no history of bleeding manifestation, pruritus, pale stools, no history of altered behavior, no history of Cox or Cox contact. There is a similar complaint in March 2025 where the child was admitted with a complaint of cough and high colored urine. The child was started on liver supplements. It spontaneously subsided on its own only. The child was asymptomatic between these two episodes. There was no history of jaundice between these two episodes. ANC wise, the child was registered and delivered at LTMGH. ANC scans were done normal. No history of fever with rash during pregnancy. No history of comorbidities during pregnancy. Birth history, the child is a late preterm normal vaginal delivery in view of preterm premature rupture of membranes. It was a twin pregnancy, 1.4 kg birth weight, cried immediately after birth. History of NICU stay in view of ELW care or discharge on day of life 11. Immunized till date. Dietary wise, the child has a calorie deficit of 200 and protein of 8. Developmentally, the child is appropriate for age. Um, Summary.
Yeah. So, what are your thoughts on this presenting complaints? Low grade fever and gradually progressive yellowish discoloration in a 3-year-old child. Hmm?
Fever with jaundice, which is unconjugated. We don't know the history of stool color. There is high colored urine, which is telling conjugated hyperbilirubinemia, and there is no history of pallor or blood transfusion. Can be a viral hepatitis.
There's no history of vomiting or outside food consumption. So might be less likely viral hepatitis. Acute history, 5 days.
There is also similar history 5 months back. So it indicates recurrent jaundice. And no family history of recurrent jaundice. And there is no history of any hematological illness. No pallor. And these are metabolic cause.
To differentiate between any liver cell failure or some obstructive like bile duct causes, we need to know ki how was the child uh, before the onset of illness, like how is it being uh,
So she's saying that there was difficulty in putting on weight. No? Somewhere she said that the child is not gaining weight. So chronic is fine, but he said that he wants to differentiate between bile duct obstruction and something else. So that not gaining weight tells you what? If your aim is to differentiate between hepatocyte disease and bile duct disease, not gaining weight goes in favor of hepatocyte disease, right? And not a biliary tract disease. So I think all of you said yourself that viral hepatitis is not to be considered only here. Like you said, for various reasons. So that is out. Okay, it is not viral hepatitis, that you should be sure. Now, whether it's a metabolic disease, what other possibilities? Can it be autoimmune? So, any difference between the two clinically? Viral, though we are not thinking actually. And why should someone get two virals 6 months apart? So, between autoimmune and metabolic, is there anything to differentiate clinically?
History of seizures.
Why seizures? No, so hypoglycemia and seizures you expect in another metabolic disorder, a major metabolic. Correct. So, but that will not come with jaundice at 3 years of age, right? When we say metabolic disorder, we are saying a metabolic disorder which primarily affects the liver. So, we are talking of Wilson's or its prototypes. Those other developmental metabolic disorders will come much earlier if they are severe.
I think two things are clear, that this is a recurrent problem. So most of the recurrent problems are immune mediated till proved otherwise. That's number one. You already said that this therefore rules out just the viral infection. But could it be hepatitis B or C? That could be varying like this, because the manifestation could be immune mediated and not viral A or E. So what's your take on it being hepatitis B transmitted from the mother? She may be E antigen positive. So most of the times all fetuses will get that infection, will manifest early. Is that a possibility? And that would go up and down. So we said no viral infection, by means we mean A and E is not like, but coming orally. But what about B or C?
Possible, sir. But how was the child in between these jaundice episodes? If the child is doing well, points more towards autoimmune.
Talk of recurrent hepatitis, even B and C comes in the discussion. Okay, she would have come, so there's no blood transfusion, mention that also, so that there is no viral transfer. But we don't know the mother status. Okay, and therefore we keep those things open. Immune, yes, because today we see immunological disorders even very early in life. So even autoimmune hepatitis can come early in life. So all that we know is this is not viral A or E. To me, we need to consider other viral infections. But could it be malaria doing this? Fever is malaria, and then jaundice is malaria, hepatopathy.
Malaria will present with high-grade fever, chills.
It's not low grade or a fever.
No history of outside food consumption.
Since the liver causing
Recurrent jaundice is not known. And child was actually symptomatic and relieved also in 1 week in the last admission, and also child was doing well in between. Again presenting with low grade fever and jaundice, unlikely leptospira or malaria. and typhoid.
Basically, when you are typhoid, malaria, lepto, whatever, your thought process should be, suppose you take away the jaundice from that clinical presentation. Does the rest look like typhoid, malaria, lepto? Then there is no question of it being typhoid, malaria, lepto, right? Okay, that's the thought process. Okay, does it look like that? Okay. Of course, for malaria, your first argument would have been, I mean, what kind of jaundice do you get in malaria and typhoid?
Malaria unconjugated.
So again, that's a misconcept. So in malaria, unconjugated means you think it's because of hemolysis, but it is more because of a hepatopathy rather than just hemolysis, and therefore it can be conjugated, right? So the main thing is that the fever or the illness doesn't look like all these disorders. Okay, fine, come.
3 year 1 month old girl complained of fever with ectasis with a past history of similar episode, immunized till date, developmentally normal with no sign. History of liver cell failure is a case of autoimmune hepatitis or Wilson's disease. On general examination, general condition was fair. Afebrile heart rate was 120 per minute. It was regular. RR was around 27 per minute. Saturation was maintained. BP and perfusion was maintained. Icterus was present. There was no pallor, cyanosis, clubbing, edema. Subcentimetric cervical lymphadenopathy was present. Anthro-wise, the child was severe acute malnutrition according to the MUAC, with stunting. Head to toe examination, shape and size was normal, skin normal, icterus was present, no pyoid enlargement, spider nevi bleeding manifestation, everything rest was normal. Systemic examination, abdomen inspection, shape was normal, there is no distension, umbilicus is central, all regions were equally moving with respiration. No dilated scars, sinuses, veins, no lump. Palpation, inspective findings were confirmed, no local rise of temperature was present, there was no guarding or rigidity. Liver was smooth, 2 centimeters palpable below the subcostal margin, non-tender. Span was around 7 to 8 centimeters. Spleen was not palpable. Percussion, tympanic note was heard all over the abdomen, no free fluid. Cardiovascular S1, S2 was heard, no murmur present. CNS, tone power reflexes were normal. RS, air entry was bilaterally equal and clear. Actually, I was just mentioning stigmata of any chronic liver disease.
So have you seen parotid enlargement as a stigma of chronic liver disease in children? So it's a sign of adult thing usually, not in children, right? Okay. So some important things on examination which you got and how would you try to interpret them? Talk about the growth first. What is the growth looking like? 9 point something kg and 87 centimeters in a child who is 3.5 years old.
Weight is affected, sir, and also height affected. Indicates the onset was much earlier, at around 1 to 1.5 years old.
Okay. So height is more, I mean, weight is more affected than height. So that's a pattern of chronic malnutrition or systemic disease. Now you will have to double check the nutritional history also, because if it is so bad because of a liver disease, then the symptoms seem to be a little less or disproportionate to so much of growth affection, right? So you'll have to look at your nutritional history a little more carefully, whether it's also a contributing thing. Okay. What else? What is the size of the liver? What is, so there is no spleen, there is no free fluid, there is no edema. So what else have you got to say there is hepatocyte dysfunction? There's no other finding. So that is a little striking. So you have growth failure for sure, and you have icterus, and you have a marginally enlarged liver. These are your three findings only, right?
I think this anthropometric measures tells me that the disease started somewhere between 1.5 years of age. And that's where one episode of jaundice came. But at 5 months, at 3 years for the first time. Okay. So, but the story started earlier. Now, why was that onset at that age of a disease where jaundice was not visible? Had it been a liver disease at say 1.5 years of age, why did the jaundice come up first time at 3 years of age? And at that time also it disappeared. So my question is, could it have been very minimal that it was not even noticeable? And therefore, knowing that this started probably at 1.5 years, knowing that it has been persistently failing ultimately in health standards, further, it has been recurrent manifestation of jaundice. So put together, it is certainly not an infection alone as we talked of, but therefore we need to consider both metabolic or the immune. Now, for immune, while it's well known, why did the immune problem started so early at 1.5 years without any manifestation? Okay, and therefore that's unlikely. Could a metabolic disorder start at that age but manifesting later? Maybe. Because metabolic disorders have a wide presentation, and therefore my clinical impression with all those uh, problems that we are not able to understand is it's unlikely immune, it's likely to be metabolic, it's not likely to be viral to my mind. Then what kind of metabolic? Not Wilson's. Wilson may come at 3, 4 years of age, but it's too early. 1.5 is not. And therefore, I go back again and say that could it be one variety of PFIC? That's my first impression looking at all them. PFIC is of three types. One is recurrent, one is very slowly progressive, and one is progressing very fast right in infancy. Here, the liver is not much enlarged also. Looks like because it has been a recurrent issue, and what is recurrent in between, the disease is not worsening, maybe even improving a little. Therefore, I think my first impression is this is likely to be one of the PFICs. I know that two of them don't have GTT increase. All that we will have to check. But that's my first impression on this.
Present further.
Three or 1 month old girl complained of fever and icterus with hepatomegaly with a past history of similar episode. Immunized till date, developmentally normal with no signs of liver cell failure is a case of autoimmune hepatitis. Actually, we have not investigated this child. Yes. The total BILI is 5.5, direct component is 3.7. SGOT and PT is elevated 966 and 2083. ALP is 404. RFT is normal. Molecular is 133 and 4. CBC shows 8.3 HB with microcytic hypochromic pattern. Platelet count is 177 and WBC count is 518 or 5.18. We had gotten USG done for this child, which was normal. 3.4. 3.4. Actually, today we have already again sent the OLAP. In that, the total bill has increased to 10. Sir. With the liver enzymes going down, or the liver enzymes have come to 599 and 1302. On actually presentation, the liver enzymes outside were 2000, so they are decreasing, but the total bill is increasing. Yes, sir. HBsAg, hepatitis A, hepatitis E, Hep C is yet to come. Mother status is, yeah, she's okay. Father is also okay.
So since they haven't yet investigated further, we don't know. So whatever clinical impression we said that stands. Now we'll have to see next time. You'll have to tell us whether our clinical impression is right or no, right? Yeah. Gamma GT, etc. is also not yet done. Awaited.
Why hepatitis A and E, do they present with recurrent jaundice? But none of them will come again if it is the same. And you can't say first time it was A and second time it was E. So it's not an infection. We have not many other diagnoses. Just a thought came to my mind whether should not be forgotten the enzymopathies. But then Krigler, Nudger, and other present in a different way altogether. This is not the age of presentation also. It would not subside without treatment if it is Krigler, Nudger. So enzymopathies of the other Gilbert, but the jaundice was too much perhaps for Gilbert. Otherwise, the liver function test would be normal. But that is one thing which we'll keep in mind in some sickness, whether the Gilbert can present, and when the child is all right, the Gilbert goes.
I think as the enzymes are very high, it is severe hepatocyte damage. That must be known. But earlier it was a mild hepatocyte damage. And therefore, this is obviously a spectrum of a disorder which is changing in its intensity also. And therefore, I don't think that's only autoimmune, because the previous one also must have been autoimmune only. Now, if I remember rightly, I'll have to recheck again. Autoimmune hepatitis are of two types. One is an LK, liver and kidney, and another is that smooth muscle cytosolval. Now, in pediatric practice, that LK is not more common. The other one is more common, and that is very acutely, severely progressive disease. To me, therefore, this is not autoimmune also. Because the first episode was also autoimmune, right? And that was very mild. So this means that it is not only recurrent illness, but even a recurrent severity as well. Mild ones, severe now.
Recovered also quickly second time. Second time also, though presented with high SGOT, recovered also relatively.
No, but that's what I'm saying. So the point is, it's acutely recovering disease, but of a various severity. To me, that should not have happened with autoimmune. And especially the type of autoimmune hepatitis, if I remember rightly, often I have not read. You may have read it recently, that it's not LK type of that which go on slowly, but this is a fastly progressive in pediatric age group. And therefore, I feel it should be looking, you should look for a PPIC, and the best way is to do genetic test. मराठी बसा 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 तुम्ही घेऊन बस तुम्ही घेऊन ती पहिल्यापासूनच बारीक आहे का हो?
ना आधीपासून ती
हो, ते आधी. हा. पहिल्या
हो ती पहिल्यापासूनच बारीक आहे झाल्यापासून हो.
खेळते का?
हा खेळते ती चांगली.
ती खेळते का चांगली? का जरा सुस्त वाटते?
खेळते ती चांगली आता पण खेळते ती चांगली हा.
म्हणजे तुम्हाला ती काही कमजोर आहे असं वाटत नाही?
वेटच नाही वाढत आहे.
तुमचे वेट कमीच आहे ना. म्हणजे मग मला काय म्हणायचं त्याची आम्हाला काळजी नाही फार. ओके, मला काय म्हणायचंय, तो वजन कमी असेल पण ती खुशीत असते का नाही, ती हॅपी असते का नाही, ती खेळते का नाही, ती खाते का नाही?
खाते वगैरे पण ती आहे ना तेवढं ती आहे ना मॅश करून खायची आतापर्यंत त्यात खायची. आता 4 दिवस झाले इथं आल्यापासून ती खाते.
म्हणजे आता पहिल्यापेक्षा 4 दिवसापेक्षा आता बरं आहे का? हो, पण बाकी आता बरे दिसते. म्हणजे तुम्ही म्हणाला 4 दिवसात बरी वाटते.
नाही जेवण जेवण तसं हा ते मी मॅश करून द्यायची ना तर ते ती आता मॅश करून नाही खाते ती असंच खाते.
नीट खायला लागली. Want to check the one thing which is peculiar is she is not looking sick at all. Okay, which means that her illness is fastly recovering. Okay, jaundice is still there maybe. Okay, with this jaundice she is fairly all right. If you look at from a distance and don't look at that yellowness, she looks to be fine. Okay, now that tells me that what looked like a progressive liver disease seems to be also regressing possibly. And I think that must be a clue to them.
Sir, one comment was whether it can be Dubin Johnson.
Johnson doesn't present really with such a variability. Okay, Dubin Johnson is a persistent problem. So that's why it is not. And Dubin Johnson often presents even does not present with any symptoms at all. It's just picked up by soil. So I think possibly not Dubin Johnson. Okay. In between she has been all right. Okay. मध्ये मध्ये 4 महिन्यापूर्वी थोडी कावीळ झाली होती ना, आणि मग ती बरी झाली का? वापस बरी झाली, औषध दिलं. So again, the child got better in a short time and now also possible.
वॉज द चाइल्ड सिक? 4-5 दिवसा जास्त होती त्यावेळेला बाळ खूप आजारी होतं का तरी सुद्धा खेळतच होती?
चढायचं उतरायचं.
पहिल्या वेळेला
So the illness has not been making her much changing her activity level, etc. I think you must look possibly for a metabolic disorder, and maybe a genetic test may be the only idea which is non-invasive, and that might pick up something on it. बोलते ना सगळं सगळं समजतं व्यवस्थित. व्हेरी गुड. ती बारीक आहे त्याची काही फार काळजी नाही वाटत आहे, पण आता दुसऱ्यांना कावीळ झाली ना, त्याच्याकरता आम्ही विचार करतो काय करायचं. ओके, आय थिंक मस्ट टू सी नाही. ठीक आहे.
बारीकच आहे का अगदी पहिल्या वर्षाच्या अगोदर? म्हणजे चालायला लागली पण बारीकच होती?
बॉय जेव्हा जन्माला आलेला त्याचा वेट होतो 1 kg 600 ग्रॅम. ही 1 kg 400 ग्रॅम. मग जेव्हा जन्माला आलेली तेव्हा सेकंड डे थर्ड डे ला सुद्धा तिला जॉन्डिस दाखवलेला आणि त्यावेळेस सुद्धा ती होती. म्हणजे 2-3 दिवस हॉस्पिटलाइज होतो आम्ही इथेच होतो आणि ती 8 मंथ बेबी होती. तिला 9 मंथ कंप्लीट नव्हते झाले. मुलगा एकदम हेल्दी आहे. हिच्या कम्प्लिटली अपोझिट आहे. तो खूप हेल्दी आहे आणि तो सर्व खातो आणि तो खूप ऍक्टिव्ह आहे कम्पेअर टू हर.
One thing is clear that her smallness is due to preterm, all that. So twins. So we are not worried about that. ती बारीक आहे त्याची काही काळजी नाही. कावीळ झाली ना त्याच्याबद्दल आम्ही बोलतो. होईल बरे. ओके, थँक्यू थँक्यू थँक्यू. नमस्कार. we missed again on many points.
Okay, the weight chart, if it was there, it would have shown a very nice rising trend in the weight. So always less than third percentile. But her curve would be parallel to the lowest curve, not like this. When if you had 4, 5 weights record, we could plot it and it gives a lot of idea how the past has been. But 1.4, she may not be too bad, must have been some 6.57 at 1 year.
You had told us 1.4 at birth. So the problem is that, when you present a case, you don't have to run through it like a Rajdhani Express. I also didn't register that 1.4 kg, but we did make a point that the amount of growth failure is disproportionate to the liver symptoms. We did make that point. Now we realize there's no growth failure only. So when you present a case, such big things, you have to emphasize. You have to you have to change, modulate your voice tone to say, "Arey, it was only 1.4," something like that, right?
The other thing, we have repeatedly said this, but most of you come alternately or once in 3 times. So I have to repeat the same thing. The investigations you put down on a slide, what is abnormal. We miss something in that which we may not really pick it up also. Every part of that is important for us to analyze. And we just noted that, yes, high enzyme, okay, but we could have seen every number and made something. So take a little extra effort and put at least abnormal findings on a slide, okay, which makes a discussion much more fruitful, right? And the second thing is, whenever we end up without any clear understanding of what the disease is, you must tell us a follow-up. Otherwise, we will never learn what we could not make out. We must learn. As much as you must learn, we must also learn. Yeah, so I think next time also keep on telling us exactly what was the final diagnosis. We make our own impressions, but that may not be right. We must know that. Right?
What is happening is the fever has come, the enzymes have risen, the jaundice has come, and it has second time also. The enzymes have gone up 2000, maybe first time also it had gone up to, and have come back to normal. So there has been acute insult of the hepatocytes, self-limiting, regressing, improving, giving rise to no evidence of ill health in between. Episodic but relatively innocent.
Sir, Anjali has said that autoimmune hepatitis is type 1 and type 2. Type 1 is presence of antibodies like ANA, and type 2 is the one with anti-liver LKM antibodies. But the clinical spectrum, of course, we'll have to go and read again. And Mahesh Mohite has said that because the enzymes are so high, can it be autoimmune? And yeah, obviously low weight we said was because of IUGR.
Autoimmune shouldn't have cleared last time also quickly. Even this time seems to be doing quickly. And obviously without any treatment. So again, I think it's a natural course of events more than an autoimmune. Because of fever, we are talking about autoimmune. Okay, but fever could be the destruction of cells anywhere in the body, significant destruction. Now here, if the enzymes are high, significant number of hepatocytes are damaged. That's why the enzymes are leaking out. So it's a severe hepatocyte disease. Fever can be explained only on that, not necessarily because there is an immune inflammation. That destruction of cells itself is good enough. And therefore, I think looking at the child who is not sick, looking at all,
Jaundice was a maximum.
and therefore probably not. Of course, we go by what we have seen, but and we have not seen many things. So that's why we want to know what is the final diagnosis, because these are the conditions where only multiple tests in relevance to that would pick up a diagnosis. I would say a genetic test for PPIC is a reasonable bet in my mind. Okay, autoimmune, yes. After all, to a hepatologist, everything looks similar. You must do the test. But we are discussing clinical bedside medicine. So for us, there are limitations of talk.
Anything else you all want to say?
I think from next time onwards, if you tell us which system you are going to present, then we can get that specialist. Earlier, every time we had a specialist coming with us. But for which we must know on Monday which system. Like today, there was a good cardiology, hepatology. We could have called somebody and who could add on some latest knowledge, some deeper knowledge that a specialist has. And I think that's the only way to learn. But for which we need a tremendous cooperation and contribution from you. You can't just pick up a case at 4:45 and rush here at 5 o'clock. Then you use your cell phone and just tick mark what is to be shown. That is not right. You need to prepare by Monday, and he has to know on Monday. Then we can call 100%. We'll call a specialist. Okay, and we will have to learn from them. Okay, this is the way only to learn, but for which we will need. Do you know he takes all that brunt of not only looking at but even this. Okay. Now we will certainly call a specialist at a short notice, but notice at least Monday. We could have called both the specialists today. We would have known much more what we don't know. We could have learned from them. And I think cooperate with us on that front. We are eager to learn even now. And we have no examination. Okay. But every patient who comes to us is examining us. So your examination will not end. In fact, you will be eligible to a prolonged, lifelong examination. Okay.
So many examiners sitting outside Thayan hospital also. They may fail us, etc., etc.
Okay, our online audience, you want to say anything? Anybody?
Happy Teachers' Day, sir. Happy Teachers' Day.
Happy Teachers' Day. Happy Teachers' Day, sir.
Thank you. Happy Teachers' Day to all of us. Anything
Happy
else?
Teachers' Day, sir.
Thank you. Anything else? Any other
Thank you.
comments?
Getting a specialist is an excellent idea.
Yeah. So let's try.
Great. We can even have one online.
2 Googlies for teachers today.
Yeah. So we'll see if they can't come physically, we can try online also. Yeah.
Yes.
Okay. So thank you everyone, and we meet next Thursday at 5 o'clock.
Thank you, Amdekar, sir. Thank you, Rajesh, Dr. Khare, and all the students who presented these lovely cases.
Thank you.
Thank you. Thank you, everyone.
Thank you.